Good morning, everyone, and welcome to the leadership webinar, Understanding the Ecosystem Overview of Ontario's Healthcare System. My name is Janine Hopkins. I'm a principal at Santis Health and will be presenting the webinar today, and I will be joined by my colleague, Dan Carbon, who's also a principal at Santis Health, and we've been supported by a great project team here at OCSA. So everyone should have received a copy of the PowerPoint presentation that we're going to go through today. And I want to point out first off that this is the first of two webinars actually this month that's designed specifically for leaders in primary care, mental health and addictions in the community and home care sectors. This series is unique because it's a collaboration between 5 associations that represent these sectors, and that's namely the Ontario Community Support Association that you're members of, Addictions and Mental Health Ontario, the Canadian Mental Health Association, the Association of Ontario Health Centres, and the Association of Family Health Teams of Ontario. To allow for a high number of participants, we're holding the same seminar today for each of the sectors. So there's one for the OCSA members, one for AMHO and CMHA members, and one for the AOHC and AFDO members. This is the one, of course, for OCSA's home and CSS sector members. Deborah Simon, who's the CEO of OCSA, will provide some remarks in a moment. And I want to really thank the CEOs for their leadership, all the CEOs of the associations for their leadership on this series, and also from the many staff from the associations and actually member organizations who provided us with invaluable guidance as we plan the webinars. I want to take a few moments now to go over the purpose of this webinar. This first webinar really is designed to provide an overview of the health policy and health system in Canada and Ontario. As leaders, you're responsible for steering your organizations through a very complex and ever-changing healthcare system. And really, we've designed this so it's an opportunity to take a step back and understand the environment in which you operate at a deeper level. We're hoping to accomplish 4 main things today. First of all, we want to educate you on relevant aspects of the healthcare system, health policy, and the trends that you should be paying attention to. We want you to come away with a better understanding of what this means for your organizations, your sectors specifically, and we want to provide you with some practical ideas that can help you interpret the change that is underway and help you steer your organizations. And finally, we want to highlight the ways in which you and your sector at large can take a leadership role during a time of rapid change. So no doubt you're thinking a lot about the role of government in healthcare these days. As you know, we have an election coming up in a little over a month. And this presentation and discussion is very mindful of the unique context that we're in. But at the same time, we wanted to make sure that we designed it in such a way that it would continue to be relevant over time, regardless of any shifts in government or health policy. Because as you know very well, change in healthcare never stops. So now I just want to briefly go over the agenda before I introduce Deborah Simon, as well as a few logistics. We've designed this agenda today so that it's a mix of presentation and discussion throughout. You're going to hear a lot from us, but we want you to hear from each other and have an opportunity to dialogue as well. So following the introduction and CEO remarks, there's really 3 sections to the agenda. And each section of the presentation will be followed by 10 minutes roughly of Q&A and discussion. The first section is the Canadian health system, a macro view. Second is a focus on Ontario's health system. And the third looks at how this impacts the operating reality for each of your unique sectors. I want to emphasize that webinar 1 is meant to be a broad overview of the main features of Canada and Ontario's health system and policy. It's an opportunity, there will be an opportunity for you to get into more specific questions related to your sectors or your local areas in the Q&A today. And also in the second webinar on April 26th, that's where we'll really do a more close examination of Ontario's policy and political dynamics and what the healthcare reforms underway and the trends that will continue to face Ontario mean. So we'll get in greater depth in the next webinar. Now I just want to go over a few logistical things. If you have any technical or audio questions or issues, please call Citrix support, and the number is 1-888-259-8411. 8414. You have this number. It was provided to you in the pre-circulated materials, but I will repeat it again. And if you can always send us a chat if you don't have the number on hand. But again, it's 1-888-259-8414, and reference the webinar ID that was provided to you when you signed up. We will use the chat feature for asking questions and making comments. So the chat option is located in the bottom of your control panel. All you do is click on the plus sign and next to the word chat, and this will expand the chat box so you can type in your message. You can ask questions and make comments throughout the presentation, so anytime you're ready, but we will be addressing the questions in 10-minute slots after each of the sections are completed. SANTA's team members will go through and group the most common questions, ideas, which we'll respond to during the webinar, and we'll do our best to address as many as we can. A few questions. There were also a few questions about your own experiences, which were pre-circulated, and I hope you've had a chance to think about them. So after the last section on your operating reality that Dan's going to take you through, there'll be an opportunity to share your experience related to these questions using chat. So again, you can start writing up your examples or experiences anytime throughout the presentation, but we're going to address them after the last section is complete. There will likely be questions and comments that we won't get to during the webinar, but rest assured all the input will be saved and the associations will be creating a Q&A to put together the range of questions that we receive, and they'll be shared with you following the webinar. And lastly, the webinar will be available on each of the association's websites after today, so it can be viewed at any time for those who have missed the presentation or for those of you that want to preview some of it again. It is now my pleasure to ask Deborah Simon, CEO of OCSA, to provide some opening remarks.
Hi, thank you very much, and thanks, Janine, for that introduction, and good morning, everybody. I'm totally thrilled to be providing introductory remarks on this exciting series and webinar, and myself sitting through and listening to understanding the ecosystem overview of Ontario healthcare. As I sit and think about the remarks I wanted to say, we've come a long way from our early submission on this program back in the ministry in 2016. And as many of you know, this initiative is the brainchild of the Community Health Ontario partnership, which is a group of community-governed community organizations that came together some number of years ago. And we proposed to implement a comprehensive leadership development program for all the reasons that Janine has just listed ahead of me. And it will enable the leaders of the community and primary healthcare sectors to really acquire strong new leadership competencies and hone your leadership skills through a variety of avenues. But mostly and importantly is a way to foster collaborative work with leaders across community health subsectors. So this was an important value add to this program. What's key from the onset of a program such as this was the need for context setting, which is what the process that our facilitators are going to take you through today, really understanding the history and politics of healthcare. And we know that the healthcare system today is undergoing a significant shift at all levels, nationally, provincially, and internationally. And it's this shift that we've been engaged in for so many years. It's not new, but we know the pressure is on, and we need only look at the press today or any day and see the headlines such as Ontario to spend $23 million to create new medical residents and 30,000 new long-term care beds to be open. These are top of mind for Ontarians, and so the healthcare system is under great scrutiny right now, and we're going to need healthcare leaders today more than ever to help us influence the change. So as a CEO of an association that's constantly lobbying government and funders on the strong virtues of home and community care, I see the leadership role as being fundamental to the changes we want to see in the system. And I know that part of the shift in the transition of care from acute care hospitals to community is going to be dependent on the leadership strength that we have. The healthcare system is complex, as Janine said. It's very vested in processes and silos, and it's going to take the utmost of its leaders to change it. More than ever, frontline leaders need to find solutions from within. We can't rely on funders or LHINs or ministry for the answers. So leveraging this creativity and innovation that exists in our organizations and our communities and our clients will be needed to harness the change as we go forward. And this is where I feel leadership will play an exciting role in helping us to move our respective sectors forward with a robust toolkit of skills and knowledge. So in summarizing, I just want to say that the goal of this project from my perspective is really just to plant the seeds and start to harness some of the creativity that we require for the culture shift going forward. Given the scope of our respective sectors and the really pressing need for leadership during the transformation, we need to have this long-term sustainability of leadership within our healthcare sector. And in my opinion, it's dependent totally on programs such as this one to help us move along. So I wish us all luck in this, and I want to turn this back to your facilitator, Janine, to start on today's webinar. Thank you.
So I would now like to ask Dan Carbon, actually my colleague, to take us through the first part of the agenda.
Hi, everyone out there, and thanks to Deborah and Janine for providing the context for today's webinar. I'm really going to be jumping into the meat of the presentation, and where we're starting is by providing a macro level introduction to the Canadian healthcare system itself. And I know many of you out there might be thinking, you know, it's Thursday morning, I'm busy, I'm not really in the mood for some kind of dry history lesson about Canada's healthcare system. How is this relevant to me in the work that I'm doing on a daily basis? And I think the answer to that is the argument in response to that your association and the others that have pulled this series together would make is that the dynamics and challenges that you, as a leader in the home and community sector, your association and your overall sector deal with every day, things like the fact the continuing centrality of physicians and hospitals in our healthcare system, you know, the uneven coverage across the province for many of the services that you provide that might vary, but not only between LHINs, but even within LHINs themselves and how they're funded, how they're covered, how they're provided. You know, the relatively low levels of investment in our Canadian system in preventative care, preventative services, and also the very high levels of private pay that many of the clients you serve on a daily basis face for accessing things like dental services, drugs, or even your own services or other services such as mental health services. These dynamics, the realities that you're facing today, can be traced back directly to the political discussions and decisions that have been made by our provincial and federal governments over the past 150 years. And our belief is that by understanding how all of these pieces fit together at a macro level and understanding how our system has evolved, leaders such as those on this webinar today will be better positioned to drive forward the changes that are needed to address the current challenges that our system face. And many of those answers do need to come from leaders in the home and community care sector. So it's a real privilege to be able to be part of this webinar today. Where I'm going to start is by providing an overview of what we see as the real key, 5 key features of the Canadian system. You know, I grew up in the United Kingdom and in Vermont in the U.S. and I've experienced 3 very, very different healthcare systems. And every country in the OECD and across the world has made different decisions about the kinds of services that it covers and functions, the values in that system, how it operates, and how it's organized and managed. So if you're looking at the Canadian system from that kind of 50,000-foot level, these are 5 of the key things that would probably jump out to you. The first feature is that Canada, of course, has a federal system of government. And what that means in healthcare is that there are different responsibilities for the provincial and federal governments. While provinces have clear responsibility for organizing, funding, and overseeing the delivery of health services, the federal government has a huge fiscal role in collecting taxes and spending and reallocating those resources. In healthcare, this generally translates into the fiscal government providing money or transfers to the provinces in exchange for their agreement about providing a minimum standard across the country. This kind of federal-provincial dynamic has continued to evolve over the 151 years now of Canada's existence, with the recent health accord negotiations being just the latest example of kind of the evolving provincial-federal dynamic. The second feature that I'm going to speak to is that Canada, uniquely in the OECD, has a universal single-tier healthcare system for physician and hospital services. 100% of medically necessary physician and hospital services are provided free at the point of care with no copay and no ability for people that are covered to be able to access an alternative private pay or second tier pathway for those medically necessary services. The flip side of that, though, that's often given a little bit of short shrift in international commentary about Canada's healthcare system, is that there's quite a shockingly high degree of private pay for other non-physician, non-hospital services, and that really impacts how our healthcare system operates and performs. The fourth factor that I want to point to is that, and this factor is really tied to the fact that the reality that Canada has a federal system of government, and that the provinces and territories have so much latitude to design, organize, and fund their healthcare systems. What that means is that especially outside of physician and hospital services, you really don't have a Canadian healthcare system at all. You have 13 distinct provincial and territorial systems that all have their unique differences, strengths, and weaknesses. The fifth feature is really, how does this all come together? And Canada's kind of interesting because Canadians really like the healthcare system. They think it's doing a good job. They express high levels of satisfaction in it. And Canadians are generally pretty healthy compared to our OECD peers. We have, a strong overall life expectancy, self-reported health status, and our premature mortality is very good. Of course, there are pockets of really poor performance when you look at Indigenous communities and other marginalized groups. But overall, Canada does very well on health outcomes. Where we do very, very badly, according to our OECD peers, and this is not a criticism of any of the health service providers or the people working in them, is really in terms of overall healthcare system performance, access and timeliness to care, equity of care delivery, and disease management outcomes. And as many of you know, where Canada really kind of falls down is in the interconnectivity in our healthcare system, and particularly in providing care for complex patients who might have multiple diseases and require care across a number of providers. We don't tend to do very well in those areas of complex disease management. So this is, I guess, a timeline where I've tried to distill down 150 years of activity into a few bullet points, and I'm going to try and go through all this in under 5 minutes. So 150 years in 5 minutes. Let's see how it goes. The first thing I wanted to note here is the passage of the British North America Act in 1867, which really created Canada and became the constitution for our new country. And as most of you know, that the BNA gave provinces the exclusive authority over healthcare. I mean, the language at the time wasn't that specific. It talked about hospitals and asylums being areas of provincial responsibility, but the courts have interpreted that ever since as meaning that the provinces have broader constitutional responsibility for oversight and delivery of healthcare services. And although the federal government, through the British North America Act, had no formal role in healthcare at all, it was granted very broad fiscal powers. And what that's meant is that the federal government essentially has a backdoor into the healthcare conversation. As a recipient of significant taxation, and with its spending power, the fiscal government has been able to provide transfers to the province. In as early as 1940, the federal government was providing money to the provinces to be able to fund some new hospital constructions and some new beds. I mean, the paradox, of course, at that time was that although there might have been hospitals that have been paid for by the provinces and the federal governments across the board, there was still no broad-based public coverage for essential healthcare services. And Saskatchewan really led the charge to change this under Tommy Douglas's leadership. And the success of the Saskatchewan public hospital insurance plan led a number of other provinces to pretty quickly follow suit and cover medically necessary hospital services, which prompted the federal government to step up and say, okay, we'll provide money for provinces across Canada to be able to offer public coverage for hospital services. Of course, the interesting dynamic there was Saskatchewan, which had been paying fully on its own for hospital coverage, took the new money from the federal government, said thank you very much, and quickly turned to introduce a provincial plan to make physician services publicly covered. And although that was a very contentious move at the time, especially amongst the physician community, it was also very successful and spread rapidly across provinces. And in 1966 was really enshrined as a national standard where the federal government agreed to provide matching funds to all provinces who would offer universal hospital and physician services. So the feds would provide 50 cents on every dollar to any province that would provide universal physician and hospital services. And that was really the deal until 1977. That changed, in large part due to the evolutions of the public healthcare system. The demand for services beyond physician and hospital services, for community services, for primary care services like community health centers, for mental health services, for drugs. And the dynamic changed so that both the provinces and the federal government were looking for a new fiscal arrangement. And instead of this cost-sharing formula 50-50, under Pierre Trudeau, they introduced something called the Established Program Financing, which is essentially just a transfer to provinces. And in 1984, the Canada Health Act was introduced. And many people confuse the Canada Health Act, especially those outside Canada, with the Canadian system itself, or think that the Canada Health Act lays out everything that dictates how the Canadian system operates. And in fact, despite the often lofty rhetoric in the legislation, what it does is actually much more prosaic. All the Canada Health Act really does is it lays out the conditions that the provinces must adhere to in order to receive those federal transfers for healthcare services. And the Canada Health Act has 5 key principles that are articulated. The provinces, if they want to get federal money, that's the hook. If they want to get federal money for healthcare, they have to adhere to these 5 principles. Public administration over the insurance scheme, comprehensiveness of all medically necessary services, universality, that everyone is covered, portability, that there's coverage, even if you go traveling to another province and you leave Ontario and you break your leg in British Columbia, that there's some kind of mechanism to be able to pay for that, imperfect as it is today. And then accessibility at the point of which is probably the most contentious one, because it's 2 components. It says that all of these medically necessary services, people actually have to be able to get in and access them, which has been a point of contention in some areas in Canada where people have been waiting upwards of a year for certain kinds of surgeries. But it also says that they're free. All those services must be free at the point of pay. It's often noted that the Canada Health Act framework is really missing. It goes part way to creating a modern healthcare system. Its focus on medically necessary hospital and physician services really doesn't reflect the realities of a modern system that where a lot of services are provided outside of hospital. And there's also no reference to equity at all, which is often referenced as the missing 6th principle of the Canada Health Act. The only other 2 things to note really are the health accords in 2004 and 2017. And really, this was basically just the federal government determining how much more money it was going to give to the provinces and what it wanted in exchange. And the deal was in the 2004 and the subsequent 2017 health accords essentially was that the province would put more money on the table the feds would put more money on the table if the provinces agreed to do certain things. So in 2004, it was wait times in primary care. And most recently in 2017, the provinces agreed to direct a good chunk of the additional funding specifically to home and community care and to mental health. So kind of to summarize how all these pieces fit together, the federal government has the way they impact most Canadians is that they just have a fiscal role. They determine how much money they're going to provide to the provinces and what conditions are associated with them to try and create a baseline of a national standard across the country. They also have direct responsibility, as everyone will know, for certain populations like the armed forces, the First Nations, Inuit, and they have other functions related to supporting research, public health, and product regulation. You know, making sure that drugs are safe and effective before they're on the market. The provinces, where the bulk of the work is done in healthcare, really manage, organize, and oversee the delivery of health services. Although it is worth noting that in every province, the vast majority of services are delivered by private organizations. So organizations, not necessarily for profit, but all the hospitals in Ontario are private organizations. Physicians' offices are private organizations. Long-term care homes are private organizations. Your organizations are private organizations, not private non-profit organizations in many cases. But the government, provincial government role is to oversee those the delivery of health services, often by private organizations. And the provincial role is also to oversee the municipal role in healthcare. You know, many of you on this webinar would have interactions with your municipality. You might even get funding from them. Municipalities get directly involved in long-term care in many cases, running municipal homes, supportive housing, some community support supporting community support programs. But it is important to note that municipalities in Canada have no defined real constitutional role. They're sometimes referred to by people as creatures of the provinces, where the responsibilities and powers they have are devolved from the provinces through legislation. What that means in Ontario is that for healthcare, the province has given municipalities a clear role in public health, ambulance delivery, and the provision of some of these other services like long-term care, supportive housing, where they've the municipalities have opted to play a greater role. The next slide is really just to put things in context in between the federal and provincial government and this evolving funding relationship. I mean, it's often the case that who pays the bill calls the shots. And if you think about the fact that when Canadian Medicare was first coming to life, the deal was that it was an equal responsibility between the provinces and the federal government. And when you poll Canadians, many of them think it still should be this way, that the feds are equally as responsible as the provinces for healthcare. But the reality has shifted significantly over the past 50 years, or after the end to cost sharing and a move to fiscal transfers. The federal funding share of provincial health services went all the way down to 14% in the late 1990s. So the provinces were paying over 85% of the fare for the public health care system. You know, thanks to the health accord, the two most recent health accords, that dynamic has changed. But it's important to note that provinces still, in large part because of this funding dynamic, have tremendous latitude in how they design, operate, and run their healthcare systems. And there has been increasing diversity in how provinces function over the past, say, 30 years. Next slide. It's kind of interesting when you talk to people outside of Canada, or if you ever have the misfortune of watching Fox News when they're talking about the Canadian healthcare system. And you know, the assumption seems to be that Canada has across the board a universal single-payer healthcare system, and there's no such thing as private care in Canada. And while that's generally true for medical and hospital services, you know, at a macro level, Canada actually has a higher degree of private pay than most of our peers in the OECD, and a very, very high level of out-of-pocket pay. 15% of every, 15 cents on every dollar in Canada for healthcare services is paid directly out of pocket by people, and it's in areas like where you see this most clearly is if you look at this chart in areas like other professionals, which include dentists and optometrists. You've got almost 90% private pay. And the areas that are relevant to you, which lumped together as other institutions and other health spending, and that would include long-term care, home and community supports. You've got overall between 25 and 30% private pay, compared to around 99% private pay for physician services. So that's just an interesting wrinkle in the Canadian healthcare system that really impacts your sector tremendously. The next slide just shows this from a slightly different perspective, in comparison to our peers. So with the exception of, if you unfortunately need to have a wart removed or something like that, virtually everything else from a physician perspective is covered publicly. But when you look at dental care, medication, long-term care, and other community services, much higher degree of private pay. Next slide. So overall, what's interesting, and this slide comes from I believe CIHI, which is the Canadian Institute for Health Information. Canada spends, we look really good compared to the US, because the US spends a whopping 17% of its GDP on healthcare, and we're only at 10%. But you compare us to the rest of the OECD, predominantly countries in Europe, but also Australia and New Zealand. We spend more of our GDP on healthcare than pretty much ever than the average in many other countries. If you put the public and private spending together, altogether, we're spending $240 billion a year in healthcare. It's one of the biggest sectors of the economy, set over 10% of GDP. Healthcare is not just something that provides care to people. It's a huge social endeavor. Employs hundreds of thousands of people across the country. When you look at how this expenditure breaks down, even with the private pay included, even with all those ancillary services that would be, massage and chiropody and things like that, we're still spending about 60% of every dollar on healthcare on hospitals, drugs, and physicians. And inside government, they refer to those as the big three in budgeting. Whenever you're looking at budgeting for the healthcare system, you first look at hospitals, drugs, and physicians, because that's where all the money is spent. And if you need to make any changes, you need to consider those three factors. So then the question is, well, how does our performance stack up? What does all this money go for? What do we get out of it? And as I said at the intro, most Canadians are pretty happy with the system. 74% of Canadians, express satisfaction in the system. That gets us an A+. We're significantly above the 65% average of our peer jurisdictions. The question is, why are people so happy? In terms of access in particular, in terms of timeliness of access, it's really, really poor in terms of being able to get it to see your family doctor. 1 in 5 Canadians report over a 7-day wait. 1 in 3 Canadians report waiting over 4 hours to get into an emergency department. And half of the population is reporting over a month to see a specialist. As we noted earlier, there's also inequities in care, particularly in the non-medical and non-hospital-based services. There's a group called the Commonwealth Fund that looks at in more detail at how Canada performs and all these other against its peer jurisdictions, and then they come up with things which a lot of politicians and deputy ministers and civil servants across the country, they don't really like this very much, and they have some good justification for criticizing or critiquing the methodology. But the upshot is that out of 11 peer jurisdictions, when you put everything together in the Canadian healthcare system, according to the Commonwealth Fund, we rank 10th out of 11, with only the US behind, quite significantly behind. And the factors that are dragging Canada down are really, access related to timeliness of care, access related to cost, and then equity. Canada doesn't do very well in equity either. We're 9th out of 11, which, given the social orientations of the country, might come as a bit of a surprise, but is largely a result of those decisions that were made to cover physician and hospital services and not to ensure equitable access of coverage to other services across the country. This slide kind of says, or what's interesting about this is that despite the challenges in our system providing timely access to care and effective coordination for things like disease management, we generally do very well in terms of outcomes. We do better for outcomes than you would expect given our health system performance. And this may be due to the fact that Canada has higher levels of social cohesion than many of our peer jurisdictions. We also invest quite a lot in a number of other social services. And we know that it's not just health care services that lead to healthy lives. In fact, healthcare is probably attributable to about a quarter of health status. It's all those other things that make people healthy or contribute to making people healthy. So Canada does really well on self-reported health status, which is very important, and premature mortality, which is, you know, what percentage of our population dies before 75? How many people get to make it to old age in relatively good health? And if you break this down on a provincial level, and you look at Ontario, we talked about the differences between the provinces. Ontario kind of stands head and shoulders above other provinces in Canada. Along with British Columbia. But Ontario, if it were ranked on its own compared to those other peer jurisdictions, would do really, really well indeed in terms of health status. So this is kind of the paradox of the Canadian health system at the moment, is by a lot of these objective measures, the health care system not doing as well as it should, and costing a little bit more than it should compared to European peers, although doing a lot better than the US, but health outcomes being very, very good overall, especially in Ontario. And I think that's where we're going to turn it over to questions. It doesn't seem we have any questions yet on the feed. Does anyone have any questions on this section that they'd like to type in, and we can address them now? And if not, you can feel free to hold off and ask questions at the end, but we want to make sure that we have an opportunity to clarify or comment on anything that you might be top of mind. No? So with that, I'm going to turn it over to Janine, who's going to be leading us through the next section.
Okay, thank you, Dan. You've just had a great overview of Canada's healthcare system, and what I'm going to be doing now is to spend a bit of time really focusing in on Ontario. The roles and responsibilities, the different players, how decisions are made in theory, but actually how they are made in practice, which is a little bit different than it always seems to be. We know that the interplay between the different parts of government, between the political side of government, the civil servants, the work in the ministry, the LHINs, it can be very confusing. It's confusing for everyone. It's a complex system that's changing all the time. But we are, in particular, it's hard for you to make sense of how your organizations or as a sector, how you can actually best influence these decisions and navigate the many relationships that you have. So we are hoping to make the healthcare system a little less opaque for you and to give you some practical information that you can use, take home with you, and use in your daily work in the healthcare system. So in Ontario, this slide 24 shows that healthcare is by far the government's largest expenditure. It actually accounts for 42% of the government's overall program spending. So every year the government has a set budget and there's a finite amount of money to spend overall. That means it's very challenging for any government to find new funding for healthcare. And at the same time, we all know that demand for healthcare is growing. There's a great public expectation about healthcare. So to hold the line on healthcare spending is very, very difficult to do without reducing access to services and in so doing angering the public. And we can see that now we've kind of hit a bit of a tipping point where there's a lot of public angst about waits for services again, overcrowding in hospitals, which is in large measure a indicator that people aren't getting timely care that they need in other parts of the system. So it's not surprising now, heading into an election, that in Ontario, all the three political parties have either promised or have to increase or have implied that they will at least maintain healthcare funding. And there's a limited number of strategies that they can use to do that. They can run a deficit or debt. There's taxation always is a tool. Spending reductions in other areas to generate revenue for healthcare, or there's other tactics like selling public assets. There's really just a limited number of things that governments can actually do. So given the size of healthcare and how rapidly demand is increasing with our aging population, there's always going to be a tension between spending on urgent healthcare needs and meeting the public's expectations, while at the same time, excuse me, investing in the other areas that are critically important to society, things like employment, education, social services, and the environment. And what typically seems to happen, which you would probably feel every day, is that when there is a push to increase healthcare spending, spending on the healthcare services, other areas that contribute to health and well-being, the so-called social determinants of health, are what end up getting squeezed to free up funding for health services. So things like social assistance, education, and the environment, and that obviously has downstream impacts on health and then healthcare services. So the point of the next few slides is to make sense of who are the key decision makers and what role do they play in the healthcare system. So as you know, there's a range of players. There's a whole network of players involved in healthcare policy processes. And it can be a challenge to keep up with the people involved in their changing roles. This slide by design is a bit of a simplification because it's really important that you understand who are the key figures and at any time. But we're also acknowledging that there's a web of other players involved in funding and policy. The two most important political players are, of course, the Premier and the Minister of Health and Long-Term Care. The Premier is a leader of the elected government, and he or she is responsible for the overall government's agenda and has a major influence on where healthcare fits into that. The Premier selects cabinet ministers, including the Minister of Health, sets the healthcare mandate based on the government's policy, and often the government's healthcare agenda is already articulated in their election platform. And nowadays, the minister receives a mandate letter from the Premier spelling out exactly what they're accountable for. So you should familiarize yourself with those mandate letters. In Ontario, the Premier has their own political staff, and that includes a special advisor on health policy. And this individual provides strategic oversight on healthcare and provides direction to the minister's staff, Minister of Health staff, and others regarding the Premier's office priorities. So then there's a Minister of Health and Long-Term Care, and they're, of course, the senior most political official responsible for overseeing the government's health priorities. They lead the introduction of legislation and other policies on healthcare. They're the key spokesperson. They defend the government's decisions in the legislature and the media. And they're supported, of course, excuse me, by a large ministry that provides technical support and implements policy. He or she has a staff of in the range of 15 to 25 people, it will vary, who provide them with support on policy advice, communications, issues management, and working directly with MPPs regarding the rollout of government initiatives. The political staff can have a lot of influence on the minister, and they're also a key channel to reach the minister, so they're important people to know. And the minister is also supported by a parliamentary assistant. That's another MPP is often charged with an important portfolio. In this case, John Fraser is the parliamentary assistant, and he leads the government's work on end of life, as an example. And lastly, there's cabinet committees that have considerable impact on healthcare policy. So nowadays it is the Health, Education, and Social Policy Committee. So it's important to know who's on these committees. In terms of non-political players, the Ministry of Health and Long-Term Care and the LHINs are probably the most prominent figures. We'll get more into how the ministry operates in webinar 2. There's a whole discussion about that. But one of the main distinctions between the political parts of government and the ministry is that the ministry is nonpartisan. And the ministry's job is really to implement the policies of the government of the day, regardless of what their political stripe is. The ministry does analysis, they design options, and then they use the powers of government to execute policy and funding. But the ministry also actually directly operates a number of government programs. For example, the OHIP program, the public drug program, and they oversee the performance of agencies like the LHINs or Cancer Care Ontario. There are other cabinet ministers, of course, and ministries and levels of government that are responsible for your sectors and providing funding for your sector. So it's important to know what these ministries are. As an example, for community support services, you receive funding from the Ministry of Community and Social Services, Citizenship and Immigration, Seniors Affairs, and others, the municipal and federal governments. So we acknowledge that you know, it's not all about the Ministry of Health, but obviously they are your major funders. And of course, all sectors are influenced by the decisions that finance makes because they lead the government's budgeting process. Secondly are the LHINs, and we know that significant oversight of healthcare planning and funding has been devolved to the LHINs. The LHINs were created in 2006, and their official role is to fund, plan, and manage the performance of health service providers, including community support services, mental health and addictions, and CHCs. They don't directly fund family health teams, but the current government's intention is that family health teams will receive funding from the LHINs eventually, although physicians' fees will continue to still be negotiated directly with the ministry, and we don't foresee any change in that in anywhere in the near future. And of course, CCACs were merged into the LHINs this past year. So now what's interesting is that LHINs not only fund and oversee home and community care, but they directly deliver some of these services. So the next few slides really zero in on the LHINs. So many of you are very familiar with the LHINs because they fund you directly, and you probably work with the LHINs in your area on a number of initiatives, but you may not really understand all of the important context and background on how the LHIN model came into being and the key features of the model. So that's what I'm going to go through in a moment. And we hope this information will help you and support you in your work with the LHINs going forward. So each province, as Dan was talking about, has considerable flexibility to structure the healthcare system and oversight to meet their own regional needs and the preference of the government of the day. And virtually every province has pursued their own model of regionalization, largely through the creation of regional health authorities. So each province has also transferred authority for health and social services, including public health, to the municipal level. And the role of municipal governments obviously varies as well from government to government. The LHIN model is definitely unique. It was designed to be made in Ontario. And in fact, Ontario was the last to regionalize, so they were able to learn from other provinces' experiences. The main reason why Ontario decided to regionalize is that our healthcare system is very large and complex. We have a huge geography, a lot of diversity in terms of our population and health providers in any given area, and it was seen to be too unwieldy to manage from one head office in Queen's Park. The typical example is that the needs of Toronto and the makeup of the healthcare system in downtown Toronto, where there's a lot of academic health sciences center, is much different than the remote spread out communities in the north or the rural communities that cross Ontario. And it was felt that they needed to empower providers and stakeholders in local geographic areas so that they could then have a greater voice and greater accountability for coordinating the services for the populations that they all serve on the ground. And the LHINs are the mechanism to do that. It's important to know that the LHINs are responsible for planning and funding and performance of about half of healthcare service. So the rest of the healthcare services are actually still overseen and managed directly by the province. So specifically, the ministry is responsible for the public drug program, the insurance program, OHIP, which covers physicians, labs, and other things, family health teams still today, and a myriad of provincial programs. Funding for public health is split between the province and municipalities. And though funding for long-term care comes through the LHINs, it's important to know that the ministry has a large role in regulating what goes on in long-term care sector. So so I want to talk a little bit about the municipal government, building on what Dan was talking about. So in addition to operating the public health unit and other services, municipal governments also have a significant role in funding social programs that are important to you, such as subsidized housing, senior services, and shelters. So having so many different funders is obviously a challenge for all community-based providers, and it can lead, it is this complexity that can lead to fragmentation in services. So having so many different funders, for example, I'm using an example from primary care, but it is germane, is that given that the different primary care models are funded by different players, the family health teams and individual physicians are funded through the ministry, whereas the community health centers are funded by the LHINs. That results in different types of models, different funding levels, and different standards in some ways. Okay, next slide. So now, what is the role of the LHIN? So when the LHINs were created, they were really created to accomplish three main goals. The first one was that devolving authority for deciding healthcare priorities at the local level, that providers and the LHINs would be able to come up with more tailored and relevant solutions to reduce gaps and inequities in access. For LHINs, for example, with large and growing immigrant populations, say like Central LHIN, they are currently looking at strategies to increase access to culturally responsive services at the local level. For the Northwest, their focus is on using virtual care and other strategies to connect their remote communities with specialist services. And they're looking at ways to reduce the travel burden and reduce inequities in their Indigenous populations. The second goal for the LHINs was really to create better coordination, and the LHINs were seen as a platform for organizations to work together to coordinate services to meet the needs of geographically based populations. They obviously have a mandate to integrate services, and that's in their name, and to do this by collaborating with health service providers. And the reason for this integration mandate is really to, at the end of the day, create a more coordinated healthcare experience for clients and communities. And the third goal was really more to do with the use of resources. It was felt that regionalizing or devolving healthcare management accountability to the local level would lead to better management of healthcare dollars. So the LHINs, as oversight bodies, they are accountable ultimately to the residents in their area, but the LHIN boards are appointed by cabinet, and the LHIN boards and CEOs, they report through to the minister, and therefore through the minister to the public at large. And they have been given a number of tools. They have the power to create a single plan for their LHIN area that everyone, all the providers to align with. They have accountability agreements, as you know, and they regularly manage the performance of providers that they fund. And LHINs and providers together, it is felt by using these tools would be able to improve the way resources are used for local residents. I want to emphasize one unique aspect of the LHIN model that is really different from other provinces, and is that in Ontario, providers have maintained independent boards. In fact, in all other provinces that have regional health authorities, they actually dissolved provider boards, and all providers became part of the regional health authority under a single board. There are a lot of different views about Ontario's model, and one of the strengths of maintaining independent boards is that there is still a strong community involvement, and fundraising ability in provider organizations is seen as a strength. One criticism that you will hear, though, is that our system is overly complex. And there are so many boards that this sometimes can lead to competition rather than collaboration when collaboration is needed. So now with slide 28, I want to look specifically at what the LHINs are responsible for. Collectively, they manage about 2,000 health service provider funding agreements, and they allocate $25 billion, or about roughly just over half of healthcare expenditures. It's interesting to note that when LHINs were originally planned, the expectation was that they'd be responsible for about 2/3 of expenditures, but of course that shift has not occurred, at least yet. So the point of this next slide 29 is to reinforce that while all 14 LHINs have a consistent role and mandate, there's a lot of variability in many ways, but particularly in the number and distribution of agencies in each of the LHINs. And it's not surprising that each of the LHINs spend a lot of their resources and energy on trying to create common goals for all providers and finding ways to enable collaboration and care coordination. And their challenge is to try and get all the parts of the system connected and moving in a common direction. So a little bit more about how the LHIN model has evolved. It's important to understand that the LHINs are only in their 12th year, and while it seems like they've always been with us, they're an embedded part of our healthcare landscape, they're really young in comparison to regional systems across Canada. And by design, that they are supposed to have some variability, because the whole point is that they have the flexibility to respond to local priorities with local strategies. But it's always a tricky balance, being responsive to local needs and contexts while ensuring that there's not too much variability in services and outcomes from one part of the province to the other. And it's fair to say that all provinces that have regionalized have struggled with this. So there is, in Ontario, as in all other provinces, this ongoing tension between centralizing the management of the healthcare system and decentralizing the healthcare system. And provinces have shifted between devolving services and delivery to the local level and centralization to single provincial bodies. For example, Alberta used to have a number of very strong regional health authorities, and then they basically overnight went to a single provincial health authority, Alberta Health Services. In BC, they have regional health authorities that deliver local and regional services, but they also have the BC Provincial Health Services Authority, which is responsible for coordinating large provincial programs like cancer care. Another feature that makes Ontario's model unique is that, with the exception of home and community care services that were previously provided by the CCACs, LHINs don't deliver healthcare services. So you'll hear debates about whether the LHINs have enough authority or whether they've been able to use their mandate to have the intended impact on the health system. But the signals right now are that Ontario will continue to evolve healthcare roles to the local level. The current government's healthcare reform strategy, Patient First, has created subregions, and many of you will be familiar and be part of subregions, participating in subregions. The LHINs are responsible for creating subregions. They're really, what they are is networks of providers in an even smaller geographic area than the LHINs, and there's about 5 of these, roughly give or take 5 subregions in each of the LHIN. And they're responsible for coordinating care and achieving common goals for a population in their given area. It's really early days for subregions. And it is important to point out that many providers within the community support services and home care sector, within other sectors, already have strong collaborative relationships in their local areas. And really, the subregions, when they work well, are formalizing and really leveraging what is already working really well on the ground. It's important to point out that the Liberal Party and the PCs have both signaled that they support the idea of devolving healthcare to the local level through either networks, or in the case of the Conservatives in the past, have talked about hospital-led local hubs. Well, it remains to be seen what their platforms will be, but that's what they have moved forward on or signaled so far. So we wanted to just kind of comment on the state of regionalization in Ontario today and what people are saying. There's a lot of different views, and but this is a quote from the Auditor General in 2015. It really reflects a particular view, and I think a balanced view about Ontario's experience. So provider organizations are definitely working together better than they were to find solutions to common health systems issues, and it's felt that the LHINs have helped to facilitate that and move that along. On the other hand, the LHINs have not yet evolved to a point where they can fully achieve, together with providers, an integrated healthcare experience for citizens. There's still where the problems are in the system are in the transitions and the spaces between services. The reality is the way that the power dynamics work and decisions are made in healthcare is often different in practice than it is in theory, for better or worse. Want to talk a little bit about how decisions are made in practice. So the ministry has considerable oversight of the LHINs, and given how much the public cares about healthcare, there's a lot of political interest and involvement decisions still. And LHINs have to be cognizant of the political factors in ways in which other regional authorities are not. The reality is when there are perceived changes that impact people's jobs or power structures, this can lead to conflict and this can lead to public blowback. And that's when MPPs or the ministers can get involved in areas where maybe the LHIN has oversight. So I just want to leave you with two practical on-the-ground examples about how decisions are actually made. And this first example is the merger between the Scarborough Hospital and Rouge Valley. Now, this is a hospital example, but I think it's very germane to everyone. So back in 2013, there were attempts to merge Scarborough and Rouge Valley. To create a single hospital system for Scarborough. They got as far as the two boards actually passing a motion to support the merger, but things fell apart, largely due to resistance from the public and some physicians. The Central East LHIN played a big role in facilitating the merger. And there was also a lot of obviously political interest from MPPs and city councillors. So in 2015, the minister of the day stepped in and created an expert panel to recommend a plan for Scarborough and West Durham hospitals. And this led to the government actually making a decision to merge the Scarborough and Rouge Valley hospitals and then the Rouge Valley Hospital Ajax site with Lakeridge. So in the end, at the end of the day, the government made the decisions and the Central East LHIN was a partner, but didn't lead the decision about the integration. This last example is really relevant to the various community sectors. I want to say that the LHINs are naturally cautious, therefore, about how they approach system change, and there's some thinking that some of them might move faster or differently on structural changes in the community sector if they had more flexibility and less political oversight. But all these various headlines here point to the fact that local politicians are concerned about the optics of any changes when there's in a community provider, or the idea of a provider leaving their area. When there are mergers or integrations, they want to be assured that there won't be disruption that will be difficult for clients or affect employees. And that's why it's so important to engage MPPs and other local politicians when there's these kinds of decisions. And these headlines show that even small changes, like a health professional leaving an organization, can be a media story in some of these small communities. So while decisions are increasingly being made in an objective way based on evidence, the reality is human and political factors often win out when there's a conflict. Now I would like to see if there are some questions, and it looks like we do have a question here, and this is a question for Dan. Is there any appetite at the federal level to open up the Canada Health Act and balance out the spending across the full healthcare continuum, or in other words, force provinces to do the same?
I think there's been a lot of discussion through the years about the need for an updated Canada Health Act that would really take Canada into the second stage of Medicare to focus more on preventative services and close those access gaps for home and community services, mental health, and drugs. And I think probably the place where the discussion is most active today is on the drug front, with a discussion around pharmacare. And if you watch that discussion closely, it kind of reveals some of the tensions that are inherent in the federal role in healthcare, an expanded federal role in healthcare, and that's essentially that if the federal government is going to step in to provide a guarantee of more equitable access for these non-medical, non-hospital services across the country, the expectation of the provinces is that the federal government will pay for that. So a universal national pharmacare program with equity guaranteed by the federal government would almost certainly come with a very, very significant price tag of the federal government, say, paying 50% of the cost of that program. And you'd expect the same kind of thing in home and community care, or an investment in more upfront preventative services. So I think that the concern or the fear about the financial obligation from the federal government has really been an impediment to updating the Canada Health Act. I'd never say never, and the discussions around pharmacare show that there still are many that are actively interested in pushing the next step in the Canada Health Act.
Okay, so the next question is, why are MDs funded separately from other healthcare providers?
Yeah, that's coming back to me as well. And again, that's largely a result of the history in the Canadian system. So if you kind of look at the way physicians used to practice, they'd have a series of fee codes, and they bill people for those services. And what essentially happened in Saskatchewan and other provinces is they said, okay, we're going to create a universal fee code, fee schedule, and instead of that being paid by the person privately, the government will pay. So in Ontario, you've got the OHIP program, which says that across the province, for doing a general assessment, a doctor will get a certain amount of money. For doing all other types of procedures, they'll get, it spells out exactly what they get for the procedures that they provide. And the physician community, it's always been a kind of sacrosanct principle to them that negotiation is a bilateral negotiation between the provincial government and the representatives of the physicians. They don't want physicians getting paid differently for working in Chatham than they do in Ontario for delivering the same kind of procedure. They don't want to have to negotiate with a hospital how much they get paid in their terms of employment. And it's been incredibly important for physicians to maintain what in their perspective is a kind of clinical independence, that they don't, in most cases, physicians don't work for a primary care provider, with the exception of CHC, which is a small minority, nor do they work for hospitals. They are independent contractors who bill the provincial government, and that's very, very different than how other providers operate within the system and how they see their responsibilities.
Okay, so we have one more question, and that this question is, there seems to be a tendency to engage community much more in the healthcare system, which means passing on more responsibilities to social services support agencies. Is this correct? Is there a plan for this? So I'm going to take this question. We are actually going to be getting into this a little bit more momentarily with Dan's going to talk a little bit more about trends in funding in Ontario's healthcare system, and certainly in the second series of webinars, that is a big focus. But what we will say is that there has been an ongoing trend to not only here in Ontario, but really across Canada, to start to try and build up other parts of the healthcare system, such as community care and primary care. We know that the public prefers to get care in their community. More people want to age at home. And we know that the cornerstone of a strong healthcare system is a strong primary care and community care system. And it's also more cost effective to receive care in the community and in primary care. So that's really a major thrust of the current Patients First plan that you'll be familiar with in Ontario. So, but there are challenges to achieving that, of course, because of the way the Canada Health Act is structured and the way services are funded. And I think that's probably a good segue to the next part of our discussion that will be led by Dan.
Okay, thanks for that, Janine. And I just want to note that we see that there are a few additional questions that have come forward. The hope is to get through the rest of the webinar, and then we'll circle back to the outstanding questions if we have time to get through all of those. The next section that we're going to be talking about, which is very, very relevant to all of you, is a discussion about the funding environment that you operate in. The funding environment, the level of funding you receive, how it's allocated, and the accountabilities associated with that really directly impact your operating reality on a day-to-day basis. It really determines how many clients you can serve, how you can serve those clients, how much you can invest in infrastructure and administration versus frontline service provision. It impacts how much you can pay your staff. Sometimes there are direct provisions in the funding that prohibit you from paying your staff more, and there are obviously implications for the recruitment and retention of your staff, given the funding environment. And finally, there's really an existential or sustainability component to funding. A lot of organizations, particularly over the past decade, have realized that in the funding environment, they haven't been able to continue providing operations to the level of quality that they've hoped to their client population, and have been forced or compelled to kind of seek integration with other partners that can address some of the challenges they've been facing. The next slide really kind of puts this in context a bit. You've had since the recession in 2008, there's been a prolonged period of healthcare austerity in Ontario of annual increases in the system that have been dramatically below the level of demand growth, and this is really because what happened in 2008 is that government revenues dropped off a cliff. So the money that the government got from corporate tax revenues and personal tax revenues really went down dramatically overnight, but demand for social services actually went up. So in times of recession, in tough economic times, the demand for social assistance actually goes up. The demand for mental health services goes up. The demand for broader healthcare services went up. So you had almost this perfect storm where the government didn't have any money while the demand for care went up, and they put in what was essentially a 10-year plan to get back to a balanced budget. The deficit in 2009, I think, was forecast at $25 billion, which is a very significant amount for a subnational jurisdiction. And the plan that Ontario had was really predicated on slowing the growth in all public services, really keeping it as close to no growth as possible. And because healthcare is 42%, as Janine said, of what the government does, that really required a close look at the healthcare system in an effort to try and keep healthcare spending really in check. And healthcare organizations really have been facing growth in the overall budget of healthcare in the neighborhood of 1% to 2% a year since 2010. And I think there's a recognition from the part of government that this is a very challenging environment. This amount of funding has been just around the level of inflation, but you've got to add in the fact that Ontario's population is growing significantly. I think our population is growing at over 1% a year, and in many places like the Central Line is exploding far faster than that. You've also got population aging, a much higher incidence of chronic diseases, and you've got new treatments coming online that offer kind of breakthrough therapy for people, but are also really expensive and drive demand. The economist Don Drummond in 2009 estimated that if we didn't change anything, if organizations did exactly what they were doing, you'd need to increase funding 6.5% every year just to continue providing the same kind of quality and level of service. And instead, we've been dealing with 1 or 2% growth. So, in the government, the government's belief was that in order not to see massive reductions in access or quality in healthcare services, they would have to make changes in how the system was funded and how it was organized, and ultimately put some heat on to change how services are delivered at the front line. Throughout this period, there's really been a relentless push for efficiency in service delivery and looking at new models of care. There's also been a push in shifting services out of the hospitals and away from expenditure on physicians to more to the community sector. And notwithstanding the recent increases that you might have seen in the recent budget and in the fall, throughout until the last year, hospital budgets were essentially flatlined, and physicians were subject to a wage freeze and cap on billings since around 2012. Okay, the next chart shows that, although this has been the most acute in the past few years, what's happening is part of a longer term trend. So this is about almost 20 years of shift. And you see that although hospitals, physicians, and drugs still make up a good chunk, the hospital share of the overall health system has dropped by about 5% over the past 17 years. So it's a pretty significant, although very incremental and iterative approach of shifting services out of hospital. Just to put this in context, and this is an imprecise chart, but the funding level for hospitals has been below, and this includes volume for funding for new services, new volumes, things like that, has been just over half that what community programs have received. And this community programs bucket is a bit messy, but it would refer to a lot of community support services and community mental health programs that a lot of you would be involved in delivering. Got it. So if you take a step back and you look at the key kind of funding dynamics, I've already talked about the fact that there's been massive growth in demand, but essentially fixed supply of dollars going into the sector to address that demand. What that's meant for providers is that you've been generally given a fixed budget in many cases and told to live within your means, find efficiencies from within, do things better, maybe deal with staff attrition and not fill that position as well, and put as much money as you can on the front line. In terms of new funding opportunities, funding has generally only gone for new services, new service volumes, which you've seen in the home and community care sector in particular, but also targeted funding for new care models where there's really a requirement for the service provider to show that they're implementing evidence-based pathways that improve outcomes. And in many cases, LHINs are requiring that those providers collaborate with other providers across the care environment that they operate in. And you're going to see that a lot more, we believe, with the sub-region model of LHINs. So what do these dynamics mean for you? Which is the next slide. Really, you've experienced little to no base budget increases and limited ability to increase salaries. There was actually a funding freeze for a long period of time. Primary care had an annual, family health teams had a funding freeze for 10 years. Many of you would have experienced freezes for almost as long. There's been widespread staff retention challenges with people often fleeing to acute care, even if they fundamentally like the work that they're doing. The pay gap between the community sector and the acute care sector has remained pretty wide, and with constraints in the community sector, it's been very challenging for certain providers to retain their staff. And then there's been this ongoing, I guess, the community sector's always operated on a bit of a shoestring very efficiently, but that pressure for efficiency and innovation and developing new business models has grown ever more acute over the past few years. And I already mentioned the funding being tied to new volume growth. So what's been interesting, I guess, out of it, there's that expression that necessity is the mother of invention. And although this has been a very tough time for many providing services in the sector and those directly on the front lines, it is also the environment, the pressure to address growing demand and growing needs in the community really has, in many cases, unleashed entrepreneurialism and innovation within the sector, where there's been a whole host of new service models and ways of caring for the population in collaboration with other providers that just didn't exist 10 years ago. And your organizations and your associations have really been at the forefront of this change. Then on the next slide, I guess a lot of you would have probably seen the news about the 2018 budget, which for the home care sector even included a rate increase for nursing, personal support, and therapy, which was long welcomed and seen as overdue. The question is, does this budget mark an inflection point? Is the era of healthcare austerity over? And I guess the answer to that is we need to reserve our judgment. We know that this budget, which projects almost 5% annual growth in healthcare spending, and that includes base increases for many sectors for the first time in 10 years, this budget will only go forward if this current government is reelected. It's essentially an election budget. If there's a change in government in June, if the progressive conservatives are elected, or if there's a minority government, it's likely that there would be a new budget introduced. So it's unclear at this point whether this what seems to be a marking of an end of the healthcare austerity agenda and a recognition that organizations have been cut so lean and are running so efficiently that they need a little bit of headroom to invest in infrastructure and administrative capacity. It really is dependent, I guess, on the election cycle and how that shakes out to see whether this is going to come to bear. The next slide, I referenced this already, but we did want to talk about the work that your sectors have been doing across the broader home and community sector to really lead the change, and just call out some of the specific initiatives. You know, in primary care, working on the Community Hubs initiative, and mental health and addictions, the role that the association and organizations have done in ensuring that the need for mental health services is really kept at the forefront. And that the federal and provincial governments are committed to mental health investment. And in the home and community care sector, really driving a lot of the discussion for around a need for a revamped, more equitable, better resource, fairer home and community sector that's led to the expert reports that have been done by Samir Sinha and Gail Donner, influenced and impacted the merger of LHIN and CCACs. And the organization is now directly involved in a lot of the work that's being done at the sub-region level to create a more integrated, effective, and patient-focused or client-focused healthcare system. And I guess what we wanted to leave you with, that before we moved on to questions, is that the work that you're doing really does play a fundamental role of fundamental importance in changing how our healthcare system operates. And as much as you can have a government strategy coming down from above, you really need to marry that with inspired operational, organizational leadership from coming up from the grassroots level, bringing that understanding of client needs, an understanding of the really of the challenges in coordinating care across the system, and bringing solutions to that. I mean, these quotes are from the Change Foundation, that the quality problems occur in our system not because of a failure of goodwill, knowledge, or effort, but because of fundamental shortcomings in the way the care is organized. And I think that word is key: organized, not delivered. By far the biggest difficulty people had, and this is from their broad consultations in the system, was understanding how to move around the system. Call this a problem with care coordination, case management, or patient navigation. Any of the terms will do. And I think that this is these issues are the ones that you folks are all seized with every day. How do you work with your peer organizations, not just in the home and community support sector, but also in hospitals, long-term care, and in social sectors? So with that, we're going to go back to questions.
Okay, thanks, Dan. We wanted to just start by, we had pre-circulated a question for OCSA members, and I think we want to ask people to comment on this question if they have any experiences or any thoughts about it, but I'm just going to go through what the question was. So we wanted people to reflect on the fact that many organizations serve different LHINs and subregions and are asked to participate in multiple initiatives and tables. And this can be time consuming and hard to manage. Have you encountered this situation, and how do you decide which invitations to accept, and how do you prioritize which tables and projects you support? So I'm going to put that out there again, and if people have thoughts on that, please do comment. But we have had a couple of other questions that have come in, and so in the meantime, we're going to address those. The first one is one I think I know the answer to, but I'll see if Dan has a more precise answer. And if there are, I should say, if there are questions that come in and we don't have the exact answer, we'll endeavor to find out and add it to the Q&A that comes back to you. But this is a great question. Are there models of subregions in other jurisdictions? And so I'm going to ask Dan to start maybe, and then I may add to it.
Sure. Well, I think Janine talked about the fact that the LHIN model itself is a little bit unique across Canada, and the sub-region model would be as well. But there are a few things that you can point to as I guess proxies or similar to the sub-region model. In the UK, for a long time, they had the strategic health authorities, which were responsible for kind of planning and oversight and overall funding and quality of healthcare services across the country. And they kind of operated like LHINs. There were 5 of them, I think, at one point, and provided that oversight over large chunks of the country. And beneath them, there were smaller smaller planning units, which were called primary care trusts, which were essentially organized around primary care at the centerpiece. And they've gone through all different kinds of health reforms in the UK, but essentially at the community level, they're organized around primary care groups that would then commission services from hospital. So they'd be kind of holding the funds and responsible for the budget of all of the patients rostered to the primary care practice, and have to pay for their services, if you will, through the hospital, long-term care, and other pieces. They've now shifted that and call it something like a community commissioning model. That's similar principle. Quebec's also had a similar model where they had, I think at one point, 97 local planning kind of units where they looked to integrate care at that kind of community level. It's almost akin to a sub-LHIN or sub-region model. And then the other thing I just kind of point to is even in the provinces with a single health authority now, which would include Nova Scotia and Alberta, they've broken those down into regional planning zones where they're trying to integrate care around those kind of sub-regional planning zones.
Thanks, Dan. We've had one response to the questions so far that we put out there. So one person has responded that we choose tables and initiatives which apply to us. So for example, palliative care and sub-region planning table, since this was a new functionality. Thank you. And another one has come in. Yes, my time is at a premium due to workload and being understaffed. So I decide based on tables and committees that are relevant to the services my organization provides: palliative care, bereavement, education and training, end of life, and tables and committees that help me have a better understanding of how the system works as a whole and locally. So thanks for that. Another one has come in. Sadly, most organizations have to spend their resources by focusing on where the current funding is. And many times the LHINs dictate how mandatory any given meeting might be to a provider, but it is really challenging to be everywhere given the sub-regions. Thank you for that. So I think as we wait to see if more comments come in, we do have one more. I think we can answer one more question that came in, which is, if the funding is the same, why are there inequities in salaries for healthcare providers? So I'm going to interpret that there are inequities mostly between the different sectors, between hospitals and say community agencies versus long-term care. And I think I am going to ask Dan to comment on this because it really builds off on what he was talking about a bit in his presentation about the funding legacies and legislation. Yeah.
Yeah, I think that the funding, or sorry, that the salary disparities between the sectors, between the acute sector, long-term care sector, and home and community sector are largely a legacy of how these sectors have come up and been funded. If you look at the community support sector in particular, a large number of services were started by individuals who saw a need or a gap in the system, and they might have fundraised and generated private donations to get those initiatives off the ground. And people were really doing it. I guess the people that were providing service were doing it in large part because of their social conscience and their love of doing the work, which translated in many cases to lower levels of pay. So even when government has stepped in to provide pay, it's generally organizations have been funded at a lower level than hospital services. And if you look at jurisdictions like Quebec, where they've integrated a number of community services into with hospitals, there's been a massive increase in harmonization of pay for community services. And the Ministry of Finance in Ontario has looked at this in a number of cases, and they put the bill at several $billions just to address the wage gap between the acute sector and the community sector. So if you were to bring all of your organizations, home and community sector organizations, and merge them with hospitals and create kind of wage parity between the hospitals and the community care sector, the province would have to step up and provide a couple $billions to basically close that gap, which is for people with equal backgrounds, equal levels of expertise, getting paid generally less in the community sector than in hospitals.
Okay, so I think we're coming to the end of this webinar, and I just want to, on behalf of Santis Health, thank everyone for joining us this morning and for the dialogue. We hope that it met your expectations, and we certainly really appreciate your time and focus over the last hour and a half. So now I want to ask Kathleen of OCSA to just do some final housekeeping wrap-up comments.
Thank you, Janine. And I just want to thank Janine and Dan for such a compelling and thorough overview of the Ontario healthcare system. I think that everyone really, I assume, took so much from that in-depth description. I just want to bring everyone's attention to the evaluation. This is an opportunity for all of you to give your feedback, address things that you would like addressed in further themes or upcoming webinars that we may be hosting as a part of the Leadership Project. So once you leave the webinar, you should have a pop-up to fulfill the evaluation component, and it will be emailed to you additionally. So there'll be 2 sort of reminders to attend to that, and we greatly appreciate your feedback on this. It helps us to tailor these webinars specifically to the needs and inquiries that you have in your specific work. If you could, next week we're having our second webinar for the Leadership Project, Health Systems Leaders webinar series. And this one is entitled Making Sense of the Policies Behind Healthcare Reform. So this one is going to go even deeper into making sense of those policies and how they relate directly to you and your work. You can find that link in the way to register via the same link on the OCSA website where you had registered for the initial. We'd like to remind you to stay tuned next week for the official launch of our Leadership Project website. Currently, we're being hosted on the OCSA website, and we do have an official Leadership website coming. So please stay tuned to email notifications and our Twitter handle, which is @LeadershipON. And that's where you can find the most up-to-date information regarding anything project related and notices to come join us at our brand new website. So with that, thank you all so much for your time. We recognize how valuable it is and how scarce it is. And hopefully we will see you next week for the continuation. Take care. Bye-bye.